today is July Fool's Day, 2020, and I'm talking to Mandy Fellman. Mandy, please just give a little introduction about who you are, what you do, where you are, how long you've been doing it.
All right. My name's Mandy Fellman. I'm the Director of Practice Management for the physician clinics at Estes Park Health. So we are a hospital-based clinic with primary care and multiple specialties. I've been doing this for I've been here in Estes Park for 3 years. I've been in the biz for about 15.
Mm-hmm.
So.
And how many practitioners do you manage?
14 primary care and employed specialties, and then about another 15 or so visiting specialists.
Mm-hmm. Okay. And what do you take for a headache?
No.
So tell me, how has it been? What we're doing, you understand what we're doing here is we're making a video record that we hope will last a long time. Mm-hmm. And that will be used by researchers, historians. It'll be out in the public. So just for public people, maybe your grandkids will want to see what was happening back in 2020 during the pandemic, which certainly will be seen by everybody as a life-changing time and a culture change.
Absolutely.
So we want to make a record of this, and especially rural, because as you know, we rural people tend sometimes to not get the attention that our urban cousins get. So just start out, how has it gone starting from the beginning? Just tell the story, please, of what's going on since you first heard of COVID and started making plans.
Mm-hmm. You know, we had, I would say in February, we had started putting into place some infection prevention measures that, so that was right before the pandemic was announced. And so, you know, we had been somewhat prepared, but I don't think you can ever be fully prepared for what happened. You know, we weren't adequately prepared, nor were any of us, I think, for the shortage of PPE and, you know, talking about, you know, limiting exposures and quarantining our patients. And, you know, we never really closed our doors, but we were focused primarily on acute care for about 60 days, you know, and where do we, you know, we're a critical access hospital with no ICU beds. So, and the nearest ICU beds being 40 miles away. And what if we can't transfer patients, and how do we prepare for that? And just, you know, working through different scenarios that we might encounter and prepare for those.
So besides you, who were the leaders in this process?
Okay, so our we assembled a COVID ops team, an operations team, which was our CNO, our directors of me in the clinic, as well as med-surg, the ED, perioperative services, all of our infection prevention, all of our clinical leaders that worked through these processes to identify what we needed to do to prepare or to prepare for a surge, those kinds of things, as well as our medical staff, obviously.
And was there a particular person or a few who you related to on the medical staff? Was there somebody who was designated to lead that?
Our CNO was leading that ops team. We reached out to our medical staff as it impacted their areas. So like the hospitalists, when we were working on med-surg issues. surgeons if it for the OR, clinic, our medical director in the clinic for clinic operations, those kinds of things. So, try not to take them away from direct patient care as much as possible, but yet involving them in processes.
How much did you meet at first?
We were meeting, the core ops team were assembled every day. They set up a command center. We didn't set up incident command, but we did have a command center where the ops team met on a daily basis and were available for whatever crisis happened to arise in a day. So.
You're not still meeting daily, are you?
No. That group, when I guess it was late April, that group kind of didn't disband, but started limiting the time that they were together. And each of our departments started working on our specific initiatives, but now we have some new leaders in place, which is actually part of the interesting part of this pandemic is people having moved positions and moved to different places. So we've reconvened an ops team, but we meet weekly. We try to stay very focused. And really what we're focused on now is how do we operationalize the things that we're having to do now because of COVID, but how do we operationalize them and make them normal?
Can you give an example or two?
Yeah. So one example is testing. When we first started, we didn't have testing supplies. We didn't have any of our patients who needed to be tested. We were sending them down the hill. Eventually and that was because of supplies as well as equipment. We actually had a piece of lab equipment that went down during the pandemic, and in replacing it, we then had the capability to test in-house. So we set up a curbside testing process, which we're doing now on a limited basis for pre-ops and for our community and first responders. But, we're in a rural mountain town and we can't test at the curbside in October. How do we operationalize that and bring it in-house? We're going to have to COVID test like we do for the flu. So how do we do that? That's what I mean by operationalizing it.
I see. Now, there's been just floods of information and a good deal of it contradictory about how to manage. What sources are y'all relying on for your information? Do you have a single? I know that and it's now called Estes Park Health, right, as opposed to Medical Center?
Yes, that's correct.
When did that happen?
A couple of years ago.
Okay.
We rebranded to Estes Park Health. And the reason for that was because, we seem to have a bunch of different identities. Park Medical Center, and then we had Estes Park Medical Group, which was the clinics, and then we had Prospect Park Living Center, and all these different entities, but really we're all one. So we rebranded under Estes Park Health, and then each department underneath that.
And as I understand it, y'all are still independent. You're not affiliated with any big systems. So
that is correct.
Do you have where do you get your information? I mean, there's plenty out there, but is there in systems often there will be one central source in the system that serves as a conduit that filters the information and kind of helps you decide what to do. Have you had anything like that, or are you all figuring this out on your own?
I would say a little bit of both. So in November, we converted to Epic from our EMR. And we are on UC Health's instance of Epic. So we are our own EMR within UC Health's instance of Epic. So being part of their electronic record, we do have a lot of information that comes our way in terms of clinical tools and treatment plans and those kinds of things, including isolation and order sets and those kinds of things. But as far as information for operations in terms of cases and monitoring surge and that those kinds of things, we really are reliant upon the CDC and CDPHE, as well as Larimer County. We have our operations officer who sits on the county group, and he brings information back to us regularly. I think they meet weekly, and that comes back to the ops team every week so that we can, know what the guidance is. And because you're right, there is a ton of information out there, and even it's seems to have slowed down a bit in the first couple of months. It's like, moment to moment, literally, we were getting different guidance on whether or not, do we have to quarantine and for 10 days or for 3 days or for, just all the different recommendations.
So that's pretty well settled down. You feel like you have a pretty comfortable groove now for managing.
Yeah. I tell you, it was it was so chaotic in the beginning, and that was probably the most difficult, because it was almost impossible to know in the moment, literally, what was the guidance that we were supposed to follow, what was true and what was not.
So you never completely quit seeing outpatients? Is that right?
Correct. Yeah.
And I assume you had different streams for people with respiratory infections versus everybody else?
Yeah, actually we did. So we continued to see acute care. We during March and April, well, let me just get back up for a minute. So before COVID, before the pandemic, we were averaging 100 or so patients a day in the clinic. At our lowest point, we were averaging about 35 to 40 a day. So that gives you an idea of the impact on the practice.
And this is total or face-to-face?
This is total, face-to-face. Yeah. Okay. So, and before this, we were doing no telehealth. So, so during that, February, March, April timeframe, all of our routine physicals, routine follow-ups, those kinds of things were all canceled unless it was deemed absolutely necessary by the clinician. And they all had, went through their patient schedules and decided, I do need to see this one, I don't that one. Fortunately, being on UC Health's instance of Epic, we were able to fast track telehealth. And so I would say within the span of about 2 weeks, we launched telehealth to all of our clinicians in the clinic. So we were able to do not only screen potential COVID patients, but also do some of the routine visits that may not have required a hands-on physical exam to telehealth. But then we also tried to segment within the clinic, because we did have patients coming in. One area that we literally put up Visqueen so that it was completely separate from the rest of the clinic, and you had to be in full PPE to go behind the Visqueen. And And that's the hallway where we saw all of our respiratory or potential COVID patients.
Mm.
Early on, we had an entire hallway that was 6 exam rooms for potential COVID patients. We weren't seeing many. We were seeing a few, but not many. So, we kind of stepped that back to 3 rooms so that we had better use of our space. And then when it got to the point that the symptoms of COVID were pretty much anything,
Mm-hmm. Yeah.
It kind of became nonsensical to have those rooms segregated, because we could have a patient come in with GI symptoms and see them in the non-respiratory hallway and end up testing them in so that's kind of how that evolved. So yeah, early on, but we still do take extra precautions on our pediatric hall. So on that hallway, we see only well child checks in the mornings, and we wait for any sick visits to the afternoon. That way our babies and kiddos are a little bit more protected.
Have you seen much of the disease?
I think right now we've had 6 positives in the community. We are starting now that tourists are returning to town, so we are a tourist town.
Yes. Oh.
Yeah.
That's going to complicate everything.
It does complicate things. So, and our summer residents, we have our population we have about 7,000 year-round residents, and then about another 7,000 summer residents. So those folks are starting to come back to town, and we are seeing tourists who are coming to town who've tested positive in their home state. And they come to altitude and start having difficulties, and we're seeing them in the ED. So it's not like, we're not testing them here, and even if we did, they'd be attributed to their home state. But we are seeing more with our tourist population.
And have you had some people who've been very sick or died with the disease?
We've had 2 hospitalizations here. We actually converted 4 of our med-surg rooms to negative pressure rooms. And then visqueen that entire hallway. We did have, I think, 2 admissions to that to those rooms at one point, but they were all recovered and discharged.
Oh, that's good. That's good.
Yeah.
So you don't have intensive care available?
No. We converted 4 med-surg rooms to negative pressure rooms. We also converted, I think, 2 of our ORs to negative pressure in case in the event of a surge, we would then have 6 rooms that we could admit and manage ventilated patients if we needed to.
Well, as a physician, I can't help but give advice, solicited or not. So here's a little bit of unsolicited advice. Intensive care is very amenable to telehealth, where the monitoring is done remotely by experts, maybe in another state, and so on. So, and that helps you to keep more of your patients, do better, wider service, and so on. But I'll just throw that out.
Yeah, certainly.
When you say telehealth, does that include telephone?
Yes, it does. So, for instance, mostly what we're doing by telehealth right now is, we did some telephone visits in the early days, as well as some video visits for routine care. Now that we're able to do COVID testing, we've set up a COVID hotline. So anybody who calls in, whether they have questions, concerns, whatever the reason they're calling for related to COVID, is transferred to one of our clinic RNs. She speaks to them, screens the call, determines their, what their concerns are, oftentimes can, answer many of their questions. But if there is a need for testing, or if needs further clearance from a physician, she will schedule a telehealth visit with one of our physicians, who will then have a normal telehealth visit with them, and determine whether or not to test. And we get them on our curbside testing schedule. So that's another way that we're keeping potential COVID out of the clinic.
So how has your clinic staff responded? How have they done in the face of this?
They've done really well. I will say that we're starting to have a little bit of PTSD. Whenever volumes are down, everybody starts to worry, and we're seeing our friends and neighbors be, off work for several months. We've seen a fair number of our community move from the community because they couldn't afford to stay here. We've had to make some staffing adjustments based on volumes. We have not laid off anybody. We are having to make up some significant ground financially, but we are making every effort possible to do that while maintaining our staff. So, in our clinic, we've made some staffing changes so that, normally our primary care providers have 2 support staff, an RN and an MA. But now, we've gone to what we've gone to is a 1.25 FTE per provider. So in primary care, you have your 1 support person, and say internal medicine, we have 5 internal medicine providers, and in family practice and peds, we have 4 or 5 on any given day. So then we have 1 float person between those practices. So it puts a little bit more stress, especially if you don't have a provider to work with and you can't work that day. We've reassigned people to our entrances because we're required by the state to take temps of every person who walks through our doors. So.
And how's provider morale been?
That physician burnout is very real, especially in a rural community.
It was already, before any of this, it was already estimated around 50%.
Yeah, absolutely. And that has not, it certainly hasn't improved. They've all, like the rest of us, just dove in and took care of our patients. I think it was exacerbated a little during the height of the pandemic because, we were taking extra call because we have, internists who used to be hospitalists. And so if there's a surge, we need to have somebody on call to back up the hospitalists. And so that kind of thing. We were looking at, well, what if we have a surge to the ED and we need to send patients somewhere else? We set up in the clinic, we actually set up what we called a split triage to the to the clinic as a second ED. So, burnout for our physicians is certainly no better. But I think getting back to somewhat of a normal practice is helping.
And the governor just announced that some restrictions are going back in. They're closing bars again and so on. So ahead of a possible surge, as is happening in our neighbors to the south.
Yeah.
West.
I wasn't surprised by that because, here we're seeing, I mentioned earlier, tourists and our summer residents. A lot of our summer residents live in California, Arizona, Texas, and Florida.
Oh, of course.
Of course they do. So, and we're not the only mountain community who have summer residents from those areas. So I'm sure that's much of what we're seeing in terms of a new surge or increased cases. We're
Yeah.
not seeing an increase in hospitalizations, but certainly an increase in positive cases. So, I wasn't surprised to see that. One of the steps that we've taken here is we are screening those summer residents for a routine visit. We're delaying those for 14 days.
Mm.
If it's an acute,
good. Yeah.
But if it's a routine, they have a PCP here and a PCP in Arizona, they can wait a few days to come in.
Yeah. Well, have you seen that is it New Jersey is just banning or requiring 2 weeks of sequestration for anybody who comes from some of the hard-hit states?
Yeah. I'm not sure how they're going to enforce that.
Mm.
I
don't know how they're doing. I think it's just people who fly in, and so I don't know.
Yeah.
I don't know what they do.
Yeah.
How about you and the rest of the administrative staff? How's it been for you guys?
We're doing okay. It's we have a new CEO now, and in fact, we had a leadership meeting today where we were talking about. We've kind of been in a firefighting mode for a while, even pre-COVID. We had our Epic conversion at the end of November. Our sterilizer went down last year, and we had no OR for 6 months.
Oh my.
Yeah, which is, that's our bread and butter in a critical accident. We had a cyber attack last year. So, those are all things that you try to plan for, but you never can adequately. So we're all, I think, feeling a bit of the stress of constantly being on panic mode, I guess, But so we're just trying to operate that, how do we plan for those events?
Yeah. So what have you done to help cope?
Me individually, or us in general?
Both.
In general, for me in the clinic, I listen a lot, because everybody has a different level of fear relative to COVID. We have staff who, have health concerns that they can take care of patients, but maybe they shouldn't be in a room with a potential COVID patient, and being aware of those things. And how we bring patients in the door. Do we, we've had to move chairs out of the waiting room and get people, stagger our schedules. 8 to 5 is kind of rare these days. Some of us are 8 to 5, some of us are 8:15, some, so that we don't have a line at registration or people sitting in our waiting rooms or crossing paths in the hallway to the exam rooms. And we stopped, we're doing our rounding a little bit differently. We're having huddles in a back hallway of the hospital with our masks on and making sure we can stand 6 feet apart. But just being aware of I guess everything that we do, having more Zoom meetings and virtual meetings as opposed to in a conference room. We built a new urgent care center, which opened in May. So we were preparing for that during the pandemic. we moved our visiting specialty clinic to that building, which gives us more clinic space here. So, that's a bit of an advantage because it gives us space to spread out a bit, and be able to work not so closely together, Me personally,
Yeah.
I try not to talk about it when I go home. I'm a little bit of a news junkie, but I try not to be these days. John's retired, and he is much more of a news junkie than I am, and he doesn't have anybody to talk to until I get home. So
I've been there.
yeah.
The other way around.
Right.
Yeah, I know what that's like. So yeah, you're doing a whole lot of listening.
Yeah, a lot of listening.
Yeah. What would you say has been the greatest challenge of this whole pandemic thing?
Yeah. Wow. I would guess. I guess I would say, planning for the future and changing how we do things. Moving to telehealth. We did it very quickly, and I think we did it very well. But that's going to be a big part of our future.
Yes.
And it was always going to be part of our future. But I think it's more so now. I think the uncertainty of how long is this truly going to last? When will we have a vaccine? When will COVID become more like influenza? And then we have to convince people to take the vaccine.
Yeah.
But just the uncertainty of the future, because we all know that our volumes are down. We all know we're starting to get busy, but we also all know that there are a fair number of our patients who are still kind of afraid.
Yeah.
And are, we talk to patients almost every day who it's time for them to come in for a physical or for, to manage their medications or whatever. And they just are afraid to come into a hospital. And the best thing I can tell them is, you know what, we're safer than Safeway.
Yes.
It is true. It is true. But they've seen in the media for so long now that, the shortage of PPE and all the cases coming through the hospitals and the ICUs that are overflowing. We don't have an ICU, but the hospital's the bed of germs. So there's just that fear.
Yeah. Do you have all of the personal protective equipment that you need now?
Close. We're still rotating our surgical masks. I'm not a clinician, but I work in the clinic, so I'm in proximity to patients, and I have to wear a mask, which I normally don't.
Right.
We all rotate them every 3 days. If you're going to be in the room with a potential COVID patient, or if you feel the need, you're in full PPE with your N95 and goggles and face shield and whatnot. I tell you, the funny thing that we began to get low on recently was alcohol pads. From taking temps at the doors and cleaning the thermometers after every person. And all of a sudden, we were down to maybe a 2-week supply and couldn't get any more.
Yeah. So what did you do?
We started cutting up 4x4s and putting them in a jar of alcohol.
Yeah. I mean, back in the day, I don't think when we were in Brush, I don't think we had it, but back in the day when I was in practice, there were these little pumps.
Yeah.
And you
Yeah,
would just take a ball of cotton and put it on the pump and
we
use
found
that.
some of those too.
Yeah, I don't know if they still even make them.
I don't know, but we found some.
Oh, good. Good. Yeah.
But yeah, I mean, that's our PPE situation is better.
Uh-huh.
Things are still on allocation. So, but because we didn't have the surge that we thought we had planned for,
Uh-huh.
we're sitting okay.
Yeah. So I'll bet you it's scary though to have although you're not going to have as many visitors as you usually do,
Yeah.
but people coming from all over who you don't know.
Mm-hmm.
It's like there are two different practices in Estes. There's the
That's
bread
right.
and butter, and then there's the tourist practice, and they're very, very different.
They are very different.
And so who knows what the future holds.
Exactly. I mean, like I said, our urgent care has opened.
Mm-hmm.
So a lot of we are seeing more and more visitors going to the urgent care. Now, our urgent care, like I said, just recently opened. So they're still, learning processes and learning the system and so forth. And they don't do any COVID testing at the urgent care. So if there's a potential COVID, those will be triaged to the ED.
Mm-hmm.
But that has changed our practice a little bit because we here in the hospital clinic are not seeing as many visitors as we used to.
Yeah.
As far as the number of visitors, I know that they're limiting access to the national park by reservation, timed reservations.
Mm-hmm.
So that's helping. However, last I heard, the VRBOs were full.
Wow.
Yeah. And there was a period of time that the hotels were limiting to 50% capacity.
Mm-hmm.
I think that's now at 75%, but we have a lot of visitors in town.
Yeah. We've still got a long road to hoe here.
Mm-hmm.
We've got a long way to go. You mentioned telehealth as one of the things that the future holds. Are there other ways you think that the practice will be different when all of this is passed?
Mm-hmm. Well, certainly telehealth is going to be the main difference, I think.
Mm-hmm.
I think, uh, how we plan and prepare for a potential pandemic in the future. I mentioned a vaccine, but
Yeah.
every time we talk about a potential COVID, the symptoms they're literally anything we would triage for normally in the clinic.
Mm-hmm.
So it's hard to say.
Mm-hmm.
I think it's really hard to say, especially here because we have a relatively high, our demographic is in the older age bracket.
Yeah.
We have a lot of retirees here. We have a lot of healthy retirees here.
Mm-hmm. Oh yeah, they couldn't live at that altitude.
Yeah. Yeah. I mean, we have 90-year-olds.
Weed them. The elevation weeds them out.
Right.
Send them back down the mountain. Yeah.
Right. So yeah, telehealth is the one thing that primarily comes to mind, but it's going to change us in other ways. I just haven't quite put my finger on it yet.
I think the whole world is changing in ways we can't even anticipate.
Mm-hmm. One of the things I read and what you sent me sparked a little bit of a thought process is, we frequently have students through our clinic. One of our pediatricians hosts a student every month.
Mm-hmm.
And we had a student with us during the cyber attack.
Mm-hmm.
And last year, we had a student with us during our Epic go live and conversion. And we had a student with us at the beginning of the pandemic.
Mm-hmm.
Now, he was actually recalled back to school. All of their students were brought back from their clinicals, from their assignments. And, but all of those students who were with us during those 3 different events, each of them said, you know, I have nothing during my medical school training thus far that would prepare me for this or something like this. And when you think of a EMR conversion,
Mm-hmm.
and you're talking to a medical student who's late 20s,
Mm-hmm.
you would think that'd be pretty easy for them, but it was
Mm-hmm.
very eye-opening.
And as far as you know, none of them have dropped out of school?
Not that I'm aware of.
Well, that's good.
Yeah, right. But that's going to be interesting. We already have, you know, a physician shortage and a nursing shortage. So
Yeah,
that certainly is this is going to change the landscape a bit.
it is.
Mm-hmm.
So anything else you'd like to say, say to your grandchildren?
Well, my granddaughter is 3 now.
Uh-huh.
And every time my daughter tells her we're going to the store, she toodles off into her room and gets her mask and puts it on.
Oh, cool. Yeah.
So, you know, I'm pretty proud of her for that one. You know, what I would say to her is, some things you can't be prepared for, but be prepared for what you can. Know that, wow, change is inevitable, and change is going to be hard. But somehow we have to be resilient.
It sounds like you are. I'm not surprised.
Thank you.
Oh, really. It's been a pleasure.